Good morning, everyone, and welcome to the long COVID meeting for the Neurophysiological Society. It's a great pleasure to be chairing this session on long COVID mechanisms, risk factors, and recovery. And my name is Dr. Laura Benjamin. I'm a Principal Clinical Research Fellow at LMCB UCL and a stroke neurologist at the National Hospital for Neurology and Neurosurgery. Delighted to also introduce my co-chair, Anna Abdallah Sheikh. Hi, Anna. And she's a senior lecturer at the cardiovascular pharmacology at the University of Liverpool, and pleased that she could join us. I'm excited to introduce five fantastic speakers. Talks will be 20 minutes each. We have one double act, which will be 25 minutes. We have a 15-minute break after the first two sessions, and 30 minutes at the end for your questions, which Anna and I will put to the speakers, gaining further insight into this session. The organisers have put together a mix of talks encompassing mechanisms, risk factors, and recovery of long COVID. You will be hearing throughout the next 2 hours about neural modulation of fatigue, autonomic dysfunction, and how tilt testing can give us more insight into this, the parallels between chronic fatigue syndrome and long COVID, and also a little bit about cardiopulmonary exercise and how that can tell us about the mechanisms of long COVID. Insight into clotting and platelet, very topical at the moment. Should we be giving long COVID patients anticoagulation? Well, wait to the end and you'll find out more. So without further ado, I'd like to introduce our first speaker, Dr. Dimitris Soteropoulos. Sorry if I haven't said that correctly. He's a lecturer of motor systems neuroscience at University of Newcastle, and his title is Neural Dysregulation in Post-COVID Fatigue. Over to you, Dimitris.
Thanks very much, Laura, for the introduction, and thanks to the Physiological Society for organizing this wonderful conference and for giving me a chance to talk to you today and present some of our data. Right. So we know from the ONS studies that currently up to about 1.3 million people continue to suffer from some of the longer-term sequelae following an infection from COVID. And approximately 50% of individuals report that fatigue is one of their most primary and most common symptoms. And that translates to about 1 in 100 people. Now, fatigue is a well-known acquaintance to the clinicians, as we can see it with several different other disorders. Some of them include autoimmune and inflammatory disorders, but we can also have fatigue existing as a syndrome in its own right, and that gets often referred to as clinical fatigue syndrome. It's been challenging to try and nail down some of the precise ways to characterize fatigues, but the symptoms suggested for chronic fatigue syndrome, which I've sort of copied from the NHS website, seem quite appropriate. Not everyone will experience these symptoms at any given moment in time, but tiredness after minimal exertion, whether that's physical or mental, is quite common, as is the fact that this tiredness doesn't really resolve with rest. And we can also have problems with sleeping and thinking memory, which is now commonly known as brain fog. So why should we care about fatigue? Well, we know quite well now, there are several studies even preceding COVID that persistent fatigue can be quite detrimental to quality of daily life, and unfortunately is a good predictor of unemployment and disability. So fatigue comes at a substantial cost both to the individual and to the community as a whole. We also find that fatigue is quite prevalent to several different neurologic illnesses. I've shown a list of some here, and on the right here you can see the prevalence, the estimated prevalence of fatigue for each one, and of course it varies depending on what condition we look at. It also varies depending on what study we look at. But you can see that the prevalence is generally quite high. It can range from 1 in 4 to 1 in 9 people suffering from fatigue. If we now look at generally other chronic illnesses and look at what the predictors are for fatigue, we also see that the main predictors, such as pain, depression, autonomic dysfunction, also rely on the nervous system. And indeed, fatigue and the impact of fatigue is often described as being related to some kind of activity. That could be physical activity or mental activity, but both of these rely on neural circuitry. If we're thinking about this physical activity, that relies on the sensory motor system, and which includes areas in the cortex, brainstem, and the spinal cord. And if we're thinking about cognitive and mental activities, again, these rely on the prefrontal cortex and other motivational circuits. So for our study, we had two main questions we wanted to try and answer. One was, do we see any evidence for dysregulation in neural function in post-COVID fatigue? And is this localized to any particular system of the nervous, any particular component of the nervous system? So we recruited participants aged between 18 and 65 years. They had to have no prior history of neurological disease. For our fatigue cohort, an extra requirement was that their infection did not require a hospital stay. So this would be mostly people with mild or moderate infection. And they had to be 6 to 26 weeks after a confirmed infection. And we were able to recruit 37 volunteers for our fatigue cohort, and we also recruited 52 age and sex match controls. And what you can see here is the distribution, the cumulative proportion, the cumulative distribution of our two cohorts relative to age, and they were not significantly different. Unfortunately, we don't have any way to be 100% sure which variant our cohort was infected with. But if we extract the genomic COVID-19 genomic surveillance data, we can actually get some accurate information about the relative proportion of the different variants across time, which is shown here by the colored lines. And then if we look at when each of our subjects was infected, so each triangle here corresponds to the time of infection of each of our COVID participants, we can then estimate the probability and the likelihood for whichever variant was circulating at the time. And based on these distributions, we expect that in our cohort, at least, most of them were infected with the alpha variant. We also asked our fatigue cohort to fill in a fatigue impact scale questionnaire. And this consists of 40 questions that can be rated from 0 to 4. And for the final fatigue impact score, we simply just add the numbers. So you can get a value from 0 to 160. And these questions are designed to assess the impact of fatigue in the subject's daily life and focusing on cognitive, physical, and psychosocial functions. And the overall score reflects the functional limitation of the fatigue over the last month or so, rather than providing a measure of the actual level of fatigue. And this is a distribution we got for our fatigue cohorts. We had a broad distribution with some subjects reporting a more moderate impact in daily life, but we also had some of our subjects who reported quite a substantial impact in their daily activities. So subjects visited our lab at Newcastle University, and they were kind enough to sit for about 4 to 5 hours while we carried a series of neurophysiological and behavioral tests that were targeted to give us some information about the state of several different components of the nervous system. We had tests, so we carried out a series of tests. I'll just go through them very briefly here to give you some information. We carried out transcranial magnetic stimulation in the motor cortex, and from these tests, we're able to extract several metrics that relate to the state and excitability of cortical circuits. Through these, we can also look at inhibitory and excitatory circuits. We carried out behavioral and reaction time tasks. We also looked at the impact of sensory feedback on circuits both in the spinal cord and the cortex. We also carried out twitch interpolation tasks that allowed us to measure how well subjects were able to maximally activate their muscles. In addition to these metrics that give us information about how the central nervous system works, we also carried out tests that provide information about how the peripheral nervous system works. and this includes the connections from nerves to muscles. So we carried out a repetitive nerve stimulation that gives us information about the neuromuscular junction. We collected information about how well muscles could be activated after a fatiguing contraction, and we also measured grip force. We also collected data about the behavior of the autonomic nervous system, and we collected information relating to the heart rate, O2 saturation, temperature, and the galvanic skin response. And this is regulated by the sympathetic nervous system. So in order to look at all these tests together, each of these tests, each of these metrics had its own range of values and its own units. So to be able to compare them all together, we express the data as a z-score relative to the mean and standard deviation of our control data. And this shows all of our data here, and just let me take you through it. So this central line, the central line that we see here that says 0, this corresponds to the mean value of that metric for our control cohort. And then the purple line corresponds to the values we obtained for our fatigue cohort. So in any instance that we see the line being above the mean line, that tells us that our fatigue cohort had larger values than the control. And in any instances that we find the line below the mean, that tells us that our fatigue cohort had values that were below that of the control group. And the metrics that are highlighted in color were the ones that were significantly different between our fatigue and our control cohorts. And the color itself indicates which component of the nervous system this metric was giving us information for. So in blue, we have the central nervous system. In red, we have the autonomic nervous system. And in green, we have the peripheral nervous system. What's worth noting is that we found no significant difference in many of the measures between our two cohorts, but we did find some very specific measures that were significantly different. And I'll just take you through them now. So for these two measures here correspond to the visual reaction time. We measured this for two different muscles, the first dorsal interosseous and the biceps muscle. And in this is a simple reaction time task that subjects had to respond to a visual stimulus. And what we find is that for both muscles, our fatigue cohorts had longer reaction times, so they were slower. The start react effect, which we measured, which was significant for the biceps muscle, this is a shortening of the voluntary reaction time to a loud and startling sound. And this has been shown to be related to connections from the brainstem motor system, the reticulospinal tract. And this was also significantly elevated in our fatigue cohort, but this could be related to the fact that the simple reaction time for biceps was also elevated. We also had a significant effect in one of our TMS protocols, and this one specifically looked at the state of intercortical circuits. This is referred to as intercortical facilitation. And what we found in our fatigue cohort, this was reduced relative to that of controls, which suggests that the motor cortex was less excitable in our fatigue cohort. We also had some measures that were related to autonomic function that came across as significant. So we found that the temperature was elevated, the tympanic temperature was elevated in our fatigue cohort relative to our controls. And we found that oxygen saturation was lower in our fatigue cohort relative to controls. We found that the mean heart rate was elevated, and heart rate variability assessed by PNN 50 was reduced relative to our control cohorts. And these two measures are often used to give us information about the state of the autonomic nervous system. Finally, if we look at the state of the galvanic skin response, so this measures changes in conductance on the skin due to sweating. Sweating is controlled by the sympathetic nervous system. And this test specifically involves exposing the participants to a loud and startling sound. When we do that, we get a very big galvanic skin response, but upon repeated exposure, this response habituates over time. What we found, however, is that in our fatigue cohort, this response habituated less compared to controls. Now, what we have here is multiple statistical comparisons. So to correct for multiple comparisons, we use the Benjamini-Hochberg procedure. And when we use our more stringent statistical criteria, we find that these 4 tests survive that process. Again, we have the mean heart rate, and we have a component from each of the main parts of the nervous system. We have heart rate, intercortical facilitation, peripheral fatigue, and oxygen saturation. So just to summarize briefly what we've just gone through, not all of the measures that we looked at were significantly different between cohorts. With regards to the central nervous system, we found that we found an increased reaction time and decreased cortical facilitation, and both of these together point towards reduced excitability in cortical circuits. Our PCF cohort, in terms of the peripheral nervous system, we found that our PCF cohort, their muscles showed a reduced ability to generate force after a maximal sustained contraction. Now, this could be due to a reduced synaptic transmission at the neuromuscular junction, but given that our RNS test was normal and that test was explicitly testing for the function of the neuromuscular junction, this suggests that the deficit is intrinsic to the muscle itself. And we also found a number of measures for the autonomic system, particularly in the mean heart rate, PNN50, and reduced habituation, altogether suggest autonomic dysregulation. We then wanted to examine whether these differences were concentrated to a particular smaller subset of the participants, or was each measure clustered onto a separate subgroup in our fatigue cohort. And to tease this apart, we used clustering analysis using k-means in order to find the optimal number of clusters that would fit our data set. We looked at trying to fit cluster numbers from 1 up to 10. We used the gap evaluation criterion to find the optimal number of the optimum cluster number, and whether we used only the 4 most significant metrics, or whether we used all our metrics together, what we find is that the optimum number of cluster is 1. And this suggests that dysregulation is homogeneously distributed across our cohort rather than being focused onto a particular subset of participants. Finally, we were interested in trying to see whether we could use our data set to predict whether a particular person belonged to the fatigue or to the control cohort. And to do this, we used a multivariate analysis where we trained a linear classifier using machine learning to classify our cohort. And for the aficionados for machine learning, we regularized and cross-validated our data to avoid overfitting. And then once we train the classifier, we run several iterations and see how successful this is at classifying our cohort. And what we find is across several iterations, we get a mean accuracy of 70%, which is much more than what one might expect by chance. And through this process of classification, through the multiple iterations runs, we can also look at which features are most often selected and which features provide most information for our classifiers. And these are shown here, and the width of the bar corresponds to the fraction of times that this feature was selected. And again, we find that we see peripheral fatigue. We see the similar features as we've seen previously: peripheral fatigue, start reaction time, mean heart rate, galvanic skin response, intercortical facilitation, and visual reaction time. And this shows the 8 most commonly selected features. So to summarize, we found significant differences in our fatigue cohort on a number of neurophysiological measures. These encompass the main components of the nervous system. both the central nervous system, the peripheral nervous system, and the autonomic nervous system. And further work is needed and ongoing to try and characterize whether these measures are useful as predictive risk factors or as biomarkers for post-COVID fatigue that might then hopefully allow us to track the progression of this disease. Finally, just to say acknowledgement, I didn't do all this work by myself. These are my colleagues and collaborators on this grant. They include Anne Baker, Natalie Maffett, Alessandro Del Vecchio, Catherine McKeating, Mark Baker, and Stuart Baker. And of course, there are participants who came to the lab for 4 to 5 hours and allowed us to carry out all of these neurophysiological and behavioral tests. And just to also remind you that this afternoon, one of our collaborators, Mark Baker, is going to give a presentation on the effects of non-invasive vagus nerve stimulation on post-COVID fatigue.
Yes, I will.
Thank you.
Thank you, Dimitris, for a really interesting talk. I'm going to introduce our next speakers. We have a double act. So it's Dr. Melanie Dunny and Dr. Boone Dean, both from Imperial College London, and they were presenting autonomic dysfunction in long COVID, insights from tilt table testing.
So thank you very much for the introduction, and thank you very much to the Physiological Society for asking us to come and talk. By way of introduction, I am a geriatrician and a general physician, and Dr. Lim is a cardiologist and electrophysiologist and our syncope service at Imperial College Healthcare NHS Trust. And we are a syncope service. We see around 1,000 tertiary referrals per year and performed 800 tilt table tests per year. And we wanted to share with you some of the insights that we've had over the last 2 years or so of some of the patients being referred to our clinic with suspected long COVID autonomic dysfunction. So in around May 2020, we noticed that we were getting a change in the quality or a subtype of referrals to our clinic. And it was patients with the traditional cardiovascular autonomic syndromes, such as vasovagal syncope or orthostatic intolerance or orthostatic hypotension, that had been triggered by or shortly followed COVID infection. We're going to call this long COVID autonomic dysfunction for the rest of the talk. Looking through the referrals that we've had over the last 18 months, we've seen 39 patients with orthostatic symptoms, so that is symptoms worse on standing, and we've performed tilt table tests on 26 of these. In keeping with the data that we know about patients with long COVID, there's a female predominance greater than 2-to-1 ratio, and the mean age in the 4th or 5th decade. So predominantly people of working age, and a substantial minority are healthcare workers. These are patients being referred to a syncope clinic, so it's unsurprising that the commonest symptoms are syncope, but also a lot of patients with palpitations and fast heart rates on standing, as well as post-exertional malaise and difficulty in exercising. Of note, just under half had pre-existing orthostatic intolerance prior to the COVID infection, and that ranged from one vagal syncope in childhood to daily symptoms of head rush on standing. So before we talk about orthostatic intolerance, so that's symptoms on standing, we'll just have a very brief summary of the physiology of standing up, or orthostasis. We are bipedal animals to standing, and our physiology has had to adapt accordingly. So when a healthy adult stands, a third of the pools in the lower limb and pelvic valve. This pooling then results in a reduced cardiac venous return, and this is sensed by baroreceptors and chemoreceptors in the aortic arch and mechanoreceptors in the heart and lungs. These stretch receptors detect a reduced cardiac venous return and send signals straight off to the brainstem. The first relay station is the nucleus of the solitary tract to indicate a reduced cardiac venous return. The brainstem causes an increase in sympathetic nervous system activity chain. It also stimulates color to secrete adrenaline, so the sympathetic adrenergic system. This increase in sympathetic nervous system activity results in in blood vessel vasoconstriction in the lower limbs, and the secretion of adrenaline causes cardiac inotropy, so an increase in contractility, and cardiac chronotropy, an increase in the heart rate. These two mechanisms together cause an increase in cardiac output and an increase in blood pressure. And within 1 to 2 seconds, that healthy adult has stood up, can carry on their daily activities, and don't even know what's just happened inside. But it's not always that easy. Sometimes standing up becomes difficult, and this is the mainstay of our workload in the syncope clinic. So if for whatever reason you have a low plasma blood volume, for example, from acute illness or deconditioning, we know that astronauts, when they come back from prolonged periods in space, will have deconditioning and lower plasma volume, or if person drinks insufficient amounts, then that reduced cardiac venous return is going to be more pronounced. Similarly, if venous pooling, for example, if there's excessive venous compliance in the lower limbs, then again, that reduced cardiac return will be more pronounced. Similarly, when the signals get to the bearer reflex and then the brainstem, if there's altered sensitivity, so for example, again, venous compliance from a connective tissue disorder, then that might affect those signals. Finally, if the individual has the appropriate increased sympathetic nervous system response, but is unable to vasoconstrict the blood vessels in their lower legs and pelvis, and that might be from a connective tissue disorder or from reduced skeletal muscle mass, then there's going to again be a reduced response to the standing up, and the individual is going to develop symptoms such as syncope or pre-syncope. Similarly, when there's an excess of adrenaline circulating in the system to try to compensate for this, increase in cardiac chronotropy manifests as palpitations and fast heart rates.
So we're now going to talk about tilt table testing, and I guess the role of tilt table testing in characterizing the autonomic substrate in some of these patients with long COVID. And this is Andrea's tilt table nest, and this is an example patient, and this is what a tilt table actually looks like. The patient is connected to a PhenoPress non-invasive beat-to-beat blood pressure cuff, which I'll show you the data very shortly. Now, this is, I think, for illustration purposes, for the Physiological Society, we want to discuss physiology of tilting. This is a normal tilt table test. And you can see here, the first 5 minutes of tilting involves a supine resting state. And in this particular example of a normal response, we get a patient whose blood pressure is about 130 over 58 or 60, with a heart rate of about 78 beats per minute. And what we do after 5 minutes of assessing the baseline response is we perform a 60-degree head-up tilt. And this head-up tilt can lead up to a 15% rise in heart rate. So in this particular example, you can see the heart rate rising from 78 to around 85 or 90 beats a minute before settling down at around 82 beats per minute. So 78 to 82 beats per minute is only a 4 beat per minute rise. The blood pressure variations don't look very different. Just to highlight to you that this is an artifact, these sharp spikes that occur every minute are the calibration artifacts of our PhenoPress. What's real are these blood pressure spikes or oscillations that you can see that some would suggest are due to Mayo wave oscillations, which are central sympathetic oscillators in the brainstem that lead to this blood pressure variability that we don't normally detect unless we have beat-to-beat blood pressure sensing like we have here. When we do our manual cuff blood pressure readings, these nuanced details of blood pressures are lost. And after 20 minutes of being in a head-up tilt position, we continue with the tilt table test by giving sublingual GTN, which serves to vasodilate the splanchnic and the lower limb vessels to enhance peripheral venous pooling. And in this particular patient, which is a normal patient, we had a mild increase, I guess, in the amplitude of oscillations seen as a peak to trough oscillations here, associated with a further slight increase in heart rate to 110 beats per minute. And I consider this a normal response to tilt table testing. So let's look at, and so these testing phases are called the passive phase, just for reference, where the tilt is done in the initial head-up tilt. And then the active phase is when GTN is given to enhance that peripheral venous pooling. So we look at some examples from our tilt lab of a patient with long COVID symptoms. And this particular example is a 25-year-old male with shortness of breath and palpitations, first 5 minutes looking very similar to the tilt you just saw with the normal patient. So this patient is supine, heart rate is about 78, blood pressure is about 135/70. But here is where the difference stops. So on head-up tilting in the passive phase, what you can see is potentially an increase in blood pressure with an enhanced oscillatory pattern, as I'm showing my laser pointer. This enhanced oscillatory pattern in the blood pressure, for example, I'm picking an extreme here of 190/110, and then 10 seconds later, 150/90. And so that is a 40 millimeter blood pressure oscillation in a 10-second cyclical Mayer wave oscillation that is mirrored by heart rate oscillations here, seen between a trough of 82 to a peak of, let's say, 120 beats per minute, with the mean heart rate that I would say along here at about 110 beats per minute. And so this passive tilt response is allowing us to characterize the changes on a beat-to-beat basis of blood pressure and heart rate. And in this particular example, it leads to an increase in blood pressure, an enhanced oscillatory pattern, a tachycardia, and symptoms and data, because the patient started to develop symptoms of palpitations and shortness of breath shortly after head-up tilt, consistent with a diagnosis of postural orthostatic tachycardia syndrome, or POTS. And at 20 minutes, we gave the GTN to start the active phase of tilting. And during the active phase, the patient developed a further acceleration in heart rate to a peak of 160 beats per minute here, associated with a drop in blood pressure to a critical level, at which point the patient felt near syncopal. And so the tilt was ended. And the other thing I want every one of us here to recognize is look at the rapidity at which we can reverse such oscillations or such a blood pressure fall. So this is the tilt coming back from a 60-degree position to a flat 0-degree supine position. And look at the recovery. So within 10 or 15 seconds, the blood pressure has now come back to the baseline levels, and the heart rate has plummeted down, and within 3 minutes back to baseline levels at 80 beats per minute. In other words, this patient is unable to stand. This is a problem with standing, or so-called orthostatic intolerance. And this patient meets the definition of POTS, with additionally, in the active phase, vasovagal syncope with a VASIS type 1 mixed collapse pattern with both a cardioinhibitory and a vasodepressive response. Now, this is another example. So this on the left was the example I just illustrated in detail. Just to flick through the slides now, this is another example of a very similar pattern, but this time with an exaggerated blood pressure rise and a heart rate rise that would be consistent with a diagnosis, a clinical diagnosis of POTS. But this has occurred in the long COVID cohort in a patient who's 41-year-old female, syncope, pre-syncope, and palpitations. So what I'm going to suggest is that this group of patients with hypertension, it would be incorrect, or in my view, unadvisable to give them anything to augment blood pressure, such as midodrine or fludrocortisone, because that risks further acceleration or the hypertensive response. It risks exaggerating this hypertensive response. So we need to be guided by the mechanistic data gathered from tilt table testing. Now, this is another example of a 49-year-old woman who is short of breath, who you can see here in the passive phase after head-up tilt, mounted a tachycardia response that sits under the threshold of 30 beats a minute. So from 80 beats per minute at rest to approximately 100 beats per minute on head-up tilt, associated with symptoms, associated with a high blood pressure on initial head-up tilt, which in my mind reflects a heightened adrenergic surge. And this I would classify as sub-threshold for POTS with a high baseline blood pressure. And we call it like this so that we understand how to treat these patients in our clinic, because we don't want to give, as I say, vasoconstrictors or too many, we don't want to overshoot the blood pressure anymore. This is another example of another patient, 43-year-old male with a similar phenomenon, presenting dominantly with palpitations, and you can see the blood pressure spike and the significant oscillations you can see compared to baseline, together with a mirroring of the oscillations in the heart rate here between 60 and 110 beats per minute. So here's another example, a 48-year-old female with fatigue. And this is the baseline 5-minute on a much more expanded 5-minute scale. And look what happens here. It's a really clear example of a slight blood pressure fall, orthostatic intolerance on head-up tilt, associated with an immediate heart rate rise. And again, this very profound oscillatory patterns seen in the blood pressure mirrored by oscillations in the heart rate. Again, something that is not easily picked up in clinic with a upper arm blood pressure cuff. So this rise in heart rate is less than 30 beats a minute. And again, it's subthreshold for POTS with no real blood pressure change from a baseline. And the reason for saying this is that this patient may, in our experience, benefit from something to augment filling and blood pressure, drugs like fludrocortisone and midodrine. And finally, our group of patients who I don't really fully understand, this particular patient, which is a 28-year-old female, has low resting blood pressures and a heart rate that sits at around 100 beats per minute already at rest. So this patient is already activated, and I suspect has a higher set point for adrenaline to maintain the vasoconstriction from a low blood pressure state. But even while supine, she's in trouble. So on head-up tilt, there's a slight further acceleration in heart rate, and then this very curious saber-like patterns of oscillations, which do not fit a Mayer wave because they're occurring every 1.5 to 2 minutes. And I don't really understand the mechanisms. This is one of the great things about physiology, in that what we see still surprises us. And I'm constantly amazed at the kind of data that we get from patients. I suspect this could be a deep reset yawn or sigh, which is a pattern that we see sometimes on tilt, to reset some of the mechanoreceptors that Mel talked about, or the baroreceptors, to then start you off at a different point. But this patient keeps oscillating lower. And this in itself could be unpicked and be the subject of another hour-long conversation if we try and unpick this. This is another patient who is a 18-year-old female who's short of breath, palpitations, brain fog. Again, a very similar low blood pressure baseline, low blood pressure and passive tilt, with a slight increase in heart rate. These patients should benefit very well from vasoconstriction, plasma expansion, fludrocortisone, midodrine, fluid salt compression.
So thank you, Bruno. In summary, we've been able to look at the tilt table patterns for our patients and classify them into these individuals who fulfill the criteria for postural orthostatic tachycardia syndrome with high baseline blood pressure, those with baseline or low or normal blood pressure, and those with the sub-POTS thresholds for blood pressure, and then finally the individuals with a starting low blood pressure. Interestingly, 2 individuals had tilt table testing within normal limits. In those patients, we were then prompted to consider whether or not autonomic dysfunction was not the driving cause of their symptoms, but some of the other mechanisms of long COVID that we've been hearing about in this conference. So what can our observations tell us about long COVID autonomic dysfunction? And that's not something we're going to be able to answer. Obviously, there are a lot of studies now looking at the profiling of long COVID and long COVID autonomic dysfunction. But there are a couple of pertinent observations that almost all patients, 83%, had a marked orthostatic tachycardia. One of the postulated mechanisms for this could be adrenaline circulating to compensate for the reduced cardiac venous return and the effects of adrenaline. And possibly some of the reasons for that might be individuals with joint hypermobility or connective tissue disease, the venous pooling in the lower limb vasculature, and this excessive adrenaline response. We noticed that a significant minority of patients had overshoot vasoconstriction, as Boone mentioned. When they stood up, they had a blood pressure excess of more than 10 millimeters of mercury that was sustained. This could be due to an underlying sympathetic nervous system excess. There was a baseline hypertension in over a quarter of patients. It could be the same reason. And then finally, 66% of the actual blood pressure oscillations, and just a reminder that is understanding those oscillations in blood pressure with a peak to trough of more than 30 millimeters of mercury seen on beat-to-beat testing. And one of our potential speculative mechanisms for this could be a change or an alteration in the baroreflex sensitivity. And one cause for that could be an underlying connective tissue disease resulting in that. So what is the point in these observations? And as Boone was mentioning, it allows us to tailor the management according to the symptoms and the responses that we see on tilt table response. So for example, in the patients who have a low baseline blood pressure drop, which incidentally we didn't see very much in the tilt table tests, we want to encourage these patients to maintain or augment their blood pressure and their blood plasma volume. This is by fluid and salt repletion, by wearing compression garments to increase cardiac venous return, and at night by raising the head of the bed by 10 to 15 degrees, and this is to avoid a pressure natriuresis overnight to stop the patient passing urine and to then wake up with a better blood volume. Medications may help, so fludrocortisone, a mineralocorticoid agonist, to help retain the fluid and salt that the individual is consuming, or vasoconstrictors, alpha agonists that cause vasoconstriction in the splanchnic beds, such as midodrine. The majority of patients, as Boone was mentioning, are those with excessive hyperadrenergic response, a high heart rate and a high blood pressure. We wouldn't want to give those individuals things to augment their blood pressure. In fact, it's the opposite. So for patients with predominant symptoms of excess adrenaline, fast heart rates, palpitations, beta blockers can be helpful, particularly propranolol as a non-selective beta blocker in a low dose, or ivabradine. We're going to talk a bit more about other ways to enhance the vagal tone and thus downregulate sympathetic nervous system activity through breathing and biofeedback. But something else to mention that has been very notable in our patients, that they've had a lot of comfort and support from the online community, the long COVID community. There's a lot of yoga and exercise and breath retraining following long COVID. And this, in helping to reset the expectation gap and to work on some of the adjustments to chronic disorders, have been some of the things that have helped our patients most. Finally, we will touch, as in any sort of long COVID talk, a lot of our patients have anecdotally found help from antihistamines and certain vitamins. We know there's no evidence base to this, but this is something that our patients come and talk to us about in clinic a lot, asking about the potential benefits, and we can answer questions on that later. Coming back to breathing and biofeedback, we think that this is one of the ways that we can really help reset that hyperadrenergic response, and Boone's going to talk about that in a bit more detail now.
So it's a pet subject of mine, and one of the challenges that I face seeing patients not only with long COVID autonomic dysfunction, but with autonomic dysfunction and, for example, POTS, is that all of us in the room who consult with patients will recognize that phenotype of patient who comes in having seen several different people and who can create a fairly challenging clinical atmosphere, especially if you're pushed for time. And one of the things that I've learned to do myself, and this is potentially a selfish reason for me to maintain some sense of calm and not get emotionally triggered myself by the interactions that I have, is to do this simple breath exercise. And I urge all of us to try and learn how to do this, or do what I'm about to demonstrate next. So I give a very clear 30-minute demonstration with Mel and Trish, part of the Syncope team, on this website, Stop Fainting, which is part of the charitable website that we run, which provides free information for all patients and doctors. And it's worth clicking on Breathe Yourself Better, where we illustrate the utility of this biofeedback tool. It doesn't need to be used, because you can feel the feedback without its use. So I seldom use this tool now, but for purposes of demonstration today, this is the tool. It clips on your ear, if you can see me, and this tool links to your phone just here. And so what we're going to do is, I want us all, if possible, to try and focus on the mandala in a short while, breathing out when the mandala expands and breathing in when the mandala comes in, with a 6-second cycle. Feel your pulse if you know how to, either the carotid or more comfortably in your radial. And let's do this together. It's a journal, it's a physiological society. Let's all try and feel the physiology. So I recorded this 2 nights ago because I realized I couldn't demonstrate this live because I couldn't share from my phone. But it's essentially a summary of what my readings are and what I'm able to kind of control with respect to my own heart rate. So let's go. This is the inner balance, and I want us all to feel our pulse and take a deep breath in over 6 seconds with the mandala. And breathe out. So all of us are doing this. Just work with me and just spend 2 minutes with me. And now follow the breathe in and out with this thing. In as the ball, as I'm illustrating, moves to the right, and breathe out as the ball moves to the left. This is the heart rate, and this is the coherence graph. The heart rate here is varying in my example between 65 and 90 beats per minute. And you can see at 36 seconds, I'm gaining control and I'm pulling in my heart rate response to be in time with my respiration. And in doing so, I'm creating a sinusoidal pattern in the heart rate between 65 and 95 beats per minute. And it's allowing me to develop a higher coherence, which is a marker of autonomic balance. And the higher your coherence, the more it is said that you are more vaguely motivated or vaguely expressed. And so the sympathovagal balance shifts in favor of a calmer, more healing mode. This graph here that I paused on is called a power spectral density. It's very technical. We don't have to go into details. But essentially, as you sharpen up the power spectral density and you move to having your entire domain of breathing or frequency concentrated in here, you are improving your coherence. And so I'll play this along and I'll ask you to, whilst I'm talking, continue to breathe in this way, following this breath in and out, and see whether you can pick your heart rate rising slightly on the breath in and slowly decreasing on the breath out, as you can see in this trace here, which I did two nights ago. And the coherence should be rising. This power spectral density map should be more focused and sharp within the domains of the 0.1 or 0.08 hertz frequency that we're breathing and entraining our cardiovascular autonomic responses at. And I just wanted to illustrate that within a minute and a half here, we can achieve a fairly high coherence. If I move onwards now to the same tracing 2.5 minutes later, so I waited another minute to save time, and I stopped breathing and I stopped thinking good thoughts. This was the rate of decline of the coherence when I lost the sinusoidal pattern. And now when we play it back, and I'm going to say, after a period of non-focused breathing without any expression of positive emotions, at 3 minutes, I'm going to start breathing again. And so speeding up and down this sensor, we're going to try now to go up and down and speed up the sensor. And I want you to appreciate that we are getting more of a waveform now that looks very much like the sinusoidal pattern was seen recently. We see the coherence rising, and within about 30 seconds, we are back in the coherent state. And I think this is a very useful exercise for us as physicians in interacting with patients, but also for our patients to be able to move and shift into this very superior mode of healing. Now, I know we're running slightly short. I'm just going to summarize the end with the multifaceted profile of long COVID and actually highlight that whilst we recognize what everyone has said within this conference and the variety of mechanisms that are speculated to cause some of these symptoms of long COVID, as you can read here yourself, including autonomic nervous system, what I really want to highlight is the parable of the blind man and the elephant, the 6 blind men of Hindustan and the elephant, because my plea to all of us who are listening right here and beyond afterwards is that we need to cultivate an awareness of our specialism silos. And it's one of the greatest kind of shames or frustrations that a patient in clinic seeing a particular ologist is only going to get the specialism offered by that ologist. Now, it's not all about autonomic dysfunction. It's also not all about metabolic dysfunction. It's not all about vitamin deficiency. There are several different mechanisms for long COVID. And what we need to do as a community is raise or elevate our awareness that we are sitting in a silo and potentially serving the patients with the information that we know. And although each of us are partly in the right, it's a very nice poem, and I'd urge you all to read this. Although each of the blind men of Hindustan is describing the elephant as he sees it, i.e., if you touch a spear, you describe the trunk, you describe the elephant, as a spear if you touch the tusk. We're all right, but we're also not seeing the wider picture. And I think we all need to elevate and see the entirety of this elephant to be able to, in order to be fair to our patients. So my plea to everyone is to use a forum such as this to share ideas, to understand from each other what we can do, and the more holistic approach to help with our patients. Thank you.
I think I'm off mute. Thank you for that insightful, reflective, and combined meditative session. And also, just to say before we break off, encourage the virtual audience to contribute some questions if you have any into the Q&A box. So we have got 10 minutes. I'm sorry we've eaten a little bit into your break time for some biscuits, cake, or just a pause. And if you can come back a minute before 10:15, that will be great so that we can start on time. Thank you very much.
Welcome back from our short break. So I would like to welcome our next speaker, Dr. Carl Morton from University of Oxford, presenting the talk titled Energetic Dysfunction in ME/CFS, the Potential Relevance to Long COVID.
Thank you. Can you see my slides okay? Are they there?
Yes.
Yeah, okay, great. So thank you very much for the organisers for giving me the opportunity to talk today. So actually, this is the only talk on the programme that's not about long COVID, so it's a bit of a challenge. So a bit of background on me. So I've worked on mitochondria or biology for the last 30 years. So I'm based in Oxford at the Women's Centre at the JR. And the two people on this side that are responsible for me getting involved in ME/CFS, there's the late Norman Booth, who is a physics professor in Oxford, whose wife has ME/CFS, and Charles Shepherd, who's basically funded all of our research over the last 3 or 4 years. So they've dragged me into this. It's been a challenge, but a very interesting one too. So I'm going to take you through some of the work that we do. So just to set the context really. So this is a slide just showing how do we understand these chronic conditions. There's very many chronic conditions out there. So we don't know what the cause is necessarily most of the time. There's lots of comorbidities, which we've heard about this morning and yesterday. And there's a trigger at some point that kick these things off. And there's probably a driver that is driving the system now. And it's trying to understand how this all fits together. So in terms of long COVID, we know about COVID-19, which was the cause potentially. Or maybe it wasn't the cause, or maybe it's just part of the process. It was interesting in hearing Melanie's talk in the earlier that half the patients that had POTS had something like that before, so they were vulnerable. So there's clearly some susceptibility factors in long COVID, and probably in other conditions as well. So there's a driver that's driving the disease now, and obviously that's the key factor for us in trying to work out what we could do therapeutically to sort of slow this down or even treat the condition. In terms of ME/CFS, we know a lot more about that. We've been working on it for quite a long time. So the panel on the right just shows you some of the symptoms that we find commonly associated with the condition that we pulled out of a UK ME/CFS biobank. And you can see on the right-hand side, there's different severity groups that we've looked at. There's mild patients who probably could have normal jobs. Moderate ones may be housebound, but they can get out and about a little bit. And then there are really severe patients that are bedbound all the time, pretty much. And you can see as you go across on the heat map, as you get more severe, the symptoms become more encompassing. And what we found over the last few years is really how important it is to have other groups that are also fatigued. So we've been looking at a multiple sclerosis cohort, and you can see they're very similar in a way to the mild patients in terms of the symptoms are very similar, and obviously a healthy control. But in terms of what drives ME/CFS, we really don't know. Many patients talk about a viral trigger, possibly EBV from glandular fever, or maybe a gut infection, or even stress can be a trigger. But there's clearly other things that these people are vulnerable, other factors that are associated with them that are part of the process in why they are vulnerable to developing this condition. Because not everybody that has EBV or other things gets ME/CFS. The disease driver is key, and this is something we really try to see whether we can find out. This is an interesting slide. It shows you some of the problems of this condition. It's quite an invisible condition. There are people, as you can see on the top right, this is a strong family. So Jamie in the middle works with me. He's quite seriously infected, but he can actually work. And Laura, his sister, also has ME/CFS, and they look completely healthy when you see them like this. But Laura is housebound. She can't really get out and about. And Jennifer Bray on the top, who produced a really superb documentary called Unrest, also looks really healthy. And then you've got the other extreme, where Whitney Defoe, whose father's quite a famous scientist called Ron Davis, is really, really sick. And he just is at home and you don't see him. And people are missing from their lives. And so this is very similar to long COVID, and people can't do what they want to do in their normal lives. And so what are the problems been in ME/CFS? And I thought I just might go through this. So clinical diagnosis has been really difficult. It's quite subjective. There are no tests for this condition. And all of the treatment trials that we've had so far have been endpoint, not really very subjective questionnaires and fatigue scores. And it's caused lots of problems. You're probably aware of the PACE trial and the changes to NICE guidelines in this condition. And so there's lots of distrust between patient groups and the medical profession, and it goes both ways. And there's been very little research funding. We've existed on charity funds in the UK, so £50,000 is probably your maximum you can get from the ME Association. So it's a challenge to keep going. It's better in the US. There's some big centre grants now, £20 million. So they've seen the light and they're moving forwards. And what we need to do in the long COVID space is to get proper funding in the future. So what are the symptoms? And these have probably resonate with a lot of people. We've seen these throughout the meeting. So this inability to function normal activities can be quite profound, can be the fact that people can't go into the bathroom, can be too much for some people, but there can be a wide range here. Unrefreshing sleep, we heard yesterday that also is an issue. Cognitive impairment, and POTS and orthostatic intolerance, just some nice presentations in the earlier session. The key one really that discriminates this from, say, depression is the one in the box, so the post-exertional malaise. So the worst things of symptoms after physical effort can be cognitive or emotional. But this is really hard to quantify. You know, we just ask the question, do you suffer from post-exertional malaise? And we need a way of quantifying this, but in a way that doesn't really impact the patients. So these are the 5 key symptoms. There's a whole lot of other things that can be associated with as well. And why are we studying this condition? Because it's pretty horrible to have it. I think that would be the bottom line. So this is a SF36 comparison, looking at physical components and mental components. And it's one of the worst conditions you can have in terms of physical and mental impacts on the patient, worse than things like osteoarthritis, back pain, and cancer. So it's a clear need here. And in terms of how it affects people, there's probably more like 20 million. And unfortunately, with the long COVID and the COVID pandemic, people that now move into this ME/CFS class is going to be increased. So the cost to not just economy, but the families is going to be enormous. In ME/CFS, around about 85-95% of patients have never had a diagnosis. It's not a proper one because we can't diagnose it well. And again, like yesterday, there was some evidence in long COVID that females are more affected, like they are in many of these autoimmune conditions. So that's a sort of bit of a summary, really. This is a nice slide from Ros Ballings, who's an expert in ME/CFS from New Zealand, and it's more of a sort of potential what could be going on. So this is Epstein-Barr virus, and many of us have this as a child. I had it as a child, and you can be quite mildly affected or more severe. And after a month, most people are back to where they were, so 90%. And then some people will go into this post-viral phase, probably 9% of patients. And if you get stressed or you push yourself too hard, you can relapse. And that's quite a potential problem. But then most people get through that. So you're left with around about 1% that have an ME/CFS type condition. And they may get better or they may stay there. So COVID and long COVID-19 fits quite nicely into this profile, really. And whether we're going to see more cases of ME/CFS is still to be seen, really. So that's an interesting demographic. And what I thought I'd show you, there's lots of work around viruses now, particularly in multiple sclerosis. And so where do the mitochondria fit into a condition where we have studied it in a lot more detail? And there's a recent paper came out in Science in the last month or two, showing quite clearly, we've known for a while that EBV infection, if you don't have EBV infection, you have much less chance of developing multiple sclerosis. And they showed in this paper that there was a clear correlation of EBV as a risk factor. So that's something that's quite new. And it affects B cells, and that's something that will be a theme of the talk as we go through. So MS is a demyelination of the nerves, and you can see that on that slide. And the other thing you see in MS, which is really interesting, is that you see high levels of mitochondria in these myelinated neurons in the patients, much more than you'd expect to see. And what we know is that if you damage demyelinated neurons in a rat, you see recruitment of mitochondria to the site of damage. So the current thinking is that maybe there's more mitochondria because they've been recruited to the site of damage. But there could be other things going on here as well. And I'll come on to that in a minute. So increased mitochondria in these axons when they're in these patients, but could be related to damage, trying to do some sort of repair process. And so this is a sort of where we are with ME/CFS, and I'm going to talk really just about the ones on the left-hand side around the mitochondrial energetic dysfunction. But we do know lots of bits of the puzzle now. We're getting a lot more studies that can be reproducible. So there are things on this slide that we're pretty hard data is coming through. So it's just connecting up the pattern really is there. So in terms of energy metabolism and ME/CFS, what do we know? And one of the first studies only came out 5-6 years ago from a Norwegian group, and they looked at metabolomics profiling of patients and found some interesting data around low levels of amino acids and lipids, and also some interesting research in PBMCs looking at maybe an impairment of pyruvate dehydrogenase activity. This has not been repeated by any group. But the thing that has been repeated, and we started to look at this, is that if you take plasma from patients or serum and you add it to control cells in culture, you do see an increase in mitochondrial respiration. And they show this in the paper, and this is some work from our group on the right-hand side. So when we add patient plasma to human muscle cells with an intracellular oxygen probe, we see an increase in respiration, i.e. a drop in the oxygen in the cells. And this is something that we're currently working on. So there's something going on with the plasma that can impact energetics, and that's research that's going on in other places. And this slide really summarizes the work in PBMCs. Most of the work in ME/CFS has been on peripheral blood mononuclear cells because that's the tissue we can easily get. And there's a growing evidence there is a problem with energetics. So the top left-hand side is a paper by the group from New Zealand, so proteomic analysis, and the two papers on the right-hand side were by an excellent group from Newcastle, led by Julie Newton. And unfortunately, this group is now disbanded because of funding, because you can't keep going on these small money. And so Carl Thomas produced some really nice bits of work. And on the bottom left-hand corner, there's an interesting study from a group in Australia, and I'll just talk about those briefly. So what's interesting on this slide, so the group by Mr. Ledes basically found there was a complex 5 issue in the patients. So I don't know if I can use my pointer on this. Let's just try. I think so. So what you have here, these are the lymphocytes from blood, and if anyone's ever tried to measure mitochondrial function, it's really difficult to do it in lymphocytes. The levels are really low. They didn't see significance here, unlike some of the other studies, but there was a tendency for the patients to have low oxygen consumption rates in lymphocytes. But what you can do is you can transform these, and with EBV again, which is potentially really relevant. So a viral transformation will give you a much higher rate of mitochondrial respiration, but that doesn't then show a difference between the two groups. So the oxygen consumption rates are very similar. But if you look at the respiratory chain components of the different cell types, that the ME patients have a huge upregulation of mitochondrial respiratory chain protein, which is really interesting. So something on these cells going into culture with a transformation was able to see big differences between the patients and controls. And then the paper by Carl Thomas, again, taking cells from a patient. So these are myoblasts, these are stem cells derived that would have generated muscle, put them into culture, and then you look at their ability to drive respiration. So the glucose-driven respiration was really low, whereas the galactose glutamine driven respiration was quite normal. So this is showing a couple of things. So you can actually transfer this energetic dysfunction type properties by taking cells from patients and growing them in culture. So this makes you wonder, well, how can you do that? And potentially genetic, epigenetic pathways that could be imprinted in the cells that could be taken through into the culture, or maybe there's something else that's going into the culture, and that's something that we're quite, so could there be a pathogen that's going through, maybe a virus, maybe a bacteria that's going into the culture with them. So this is some data on just a brief snapshot. We've done a lot of work with metabolomics over the years, and we see differences in patients compared to controls, and this is just showing some amino acid ones that are quite relevant to energetics. So you can see here, this is the relative fold change compared to the controls, and things like glutamine is about half in many of the patients. So these are all down. So there's low levels of amino acids in the patients. And what does this mean? So glutamine is a really abundant amino acid in blood, and it's down by 50%. And so in terms of the glutamine, the blood concentration, 0.41 millimolar. So it's really very, very, very high. So what's going on here? And so one area could be that the patients are struggling with glucose, as was alluded to by the Norwegian group, and we're using other fuels to compensate. So there could be a drive to use glutamine to go through to make ATP, but glutamine is made mainly by muscles, so there could be a problem with the production of glutamine. And so this is an interesting area that we're exploring. So if there was a problem with glucose metabolism going into the mitochondria, maybe by PDH, there's a hypoxic regulation here, which could be also playing a role. So this is an interesting clue. The key thing to mention is we don't see this with all the patient groups, and we're trying to reproduce this. So seriously, all people aren't showing the same effect. So this may be the milder patients that are showing this interesting phenotype. So what do we do next? We've studied PBMCs. What type of things should we be doing if we have the funding? So I think the time is right to start trying to do some imaging work, to use MRI, spectroscopy. But this is expensive, and this is something we probably need to do. And a key thing is to do multiple measures. We do get a lot of variation between patient controls, and when you start digging deeper into some of these other omics technologies, you do start to see huge variability, even in the control population. So having a multiple measures, but that costs money. You need to do more than one scan on a patient. Using an intervention, either exercise or a cognitive test, could really start to tease out what is changing in these individuals in terms of their metabolism. And that's something we need to do in a sort of safe way for the patients. And there are new things that we could use. Maybe Betty Rahman will talk more about this type of thing this afternoon in her talk, but this dynamic nuclear polarization allows you to look at, say, pyruvate metabolism, so to really tease out what's going on in terms of these metabolites. And I'm going to switch tack a bit now, because I've talked a bit about the ATP. Mitochondria is the powerhouse of the cell, but we now know they do other things. And so for the last part of the talk, I want to talk a bit about how mitochondria might be involved in infection and how that might be of relevance in this condition. So on the right-hand side, you have a JC1 stained neuron, and you can see the brighter regions of where the mitochondria are. And this is a bit of a teaser slide. I haven't got time to go into it today, but a collaborator of ours is finding wall-less pathogens in patients with chronic illnesses, including ME/CFS. You can see here a white blood cell. The little green speck is an L-form bacteria. These are very non-immunogenic, and they can hang out in cells and hide in cells, and you can also culture them. So that was just a teaser, really. And as I said, I've worked on mitochondria for many years. And this is the classic mitochondrial structure that you probably were taught. And these are primary hepatocytes from human liver. And they're very punctate, look a bit like this. Whereas fibroblasts are really different. They're very long, filamentous. And I've always wondered, what's going on here? And this, so this image at the bottom here is from INS1 cells. So these were tagged with GFP in the mitochondria, and then we've got a functional stain staining the mitochondria orange, and you can see there's some cells that are green and some that have more sort of orange speckles, so these are more active, and so they're different even in a homogeneous culture. And so at the time we didn't really think much about this, but there's new work coming through that suggests this could be really important. So this is a comparison of two types of pathways. So if you have a pathogen affecting a cell, you have this PAM model here on the left-hand side, and these molecular patterns you see. And then when mitochondrial dysfunction occurs in disease or in aging, you also see something very similar. But what's quite striking is that the end point of this is the same. And so this innate immune activation can either happen from a bacteria infecting a system or mitochondrial failure. And these two systems could be quite related and quite important. And this is some recent data come from Lena Pernis group at the Max Planck, showing that bacteria like this, Toxoplasma gondii, which is found in over a third of all humans, can cause some quite catastrophic changes to the mitochondrial biology. So in the panel in the middle, you can see that what the bacteria does, it strips off the outer membrane of the mitochondria, and it renders those mitochondria less good at mounting a defense. And so there's another paper from Lena you can read in Cell Metabolism that talks about how mitochondria mount this defense type system. And on the right-hand side, you can see the red bacteria surrounded by the mitochondria in green, and it's as if they're being engulfed by the mitochondria, and that mitochondria is probably trying to control the replication of those organisms in the cell and maybe trying to get rid of them. And so this is something that's quite new and obviously a growing area that could be highly relevant here. I wanted to mention this. So this is some research from an Italian group led by Alessandro Morelli. They've been working in this area for about 15 years. Their research hasn't been widely accepted by the community, but I think it's really potentially really important. So this slide is just showing you, if you look at the mitochondrial area density in different tissues, they are really different. And you can see from this that the brain has only 5% volume of mitochondria, whereas it's one of the biggest users of oxygen in the body, the highest user of glucose. So how is it making its energy if it has so few mitochondria? And the other cell of interest is, again, is this B cell, the plasmablast. These are the cells that make the energy, the antibodies producing cells. And again, when they go into this highly differentiated state, you find out lots of ER structures forming, but very few mitochondria. And if you look at the Price paper shown below, there's a huge cranking up of the TCA cycle enzymes and respiratory chain enzymes. Well, where are they? They're not in mitochondria. So what Alessandro and the group are saying is that a lot of aerobic ATP synthesis occurs in membrane structures in humans and not in mitochondria. And this hasn't gone down very well with the mitochondrial community, but I think they need to start listening to what they're saying. Because if you go back and look at this slide, myelinated neurons don't have very many mitochondria compared to an unmyelinated neuron. So maybe that makes them vulnerable. And it's the myelin around them that may be the thing that's driving the ATP production. And a beta cell, again, why beta cells? Maybe they're more vulnerable to EBV infection, and that's part of the process. So this is something we need to bear in mind. And this is some nice work by Bupesh Prosti from Germany. He's a virologist, and you can see on the left-hand side what happens when chlamydia affect cells, and again you get this similar network structure that I showed you before with the toxoplasmosis, as if the mitochondria are engulfing the bacteria. And whereas a virus does something completely different. So if you activate herpes 6 virus, so the red cells have had it reactivated from the latent form, the mitochondria become really punctate. So you can imagine a scenario where you don't just have a bacteria in a cell, you may have a virus as well. And what happens when you see the two? And so certain tissues like the heart and the liver have a lot of mitochondria. So maybe they're very good at dealing with these viruses, but the brain seems to be lacking. Obviously, there's a blood-brain barrier that is protective. But what if things get in there? And maybe there's a problem with the brain in dealing with viruses, etc. And so if there are pathogens, where are they? What's the evidence that there's levels of infection? And there really isn't good evidence for a full-blown infection in patients with ME/CFS when they suffer from the disease. And the same for long COVID. I don't think there's probably much virus left. So what could be going on? And so this is an interesting systematic review looking at diseases, schizophrenia, depression, mental health, and chronic fatigue. And what you find is that there's a lot of evidence of a permeable gut. So you find high levels of LPS in the blood, you find other markers. So the SCD14 is a liver marker linked to the presence of pathogens, and the zonin 1 is a marker of gut integrity. It's tight junction protein. So there are evidence of pathogens in the bloodstream of these people, but at low levels. So they're getting in there, but what are they doing? And how can we think about that as a mechanism? And a recent study from one of the centers in the NIH funded centers in the US, from Lipkin's group, has shown quite nicely in a recent PLOS paper that there are things going on again with the B cell expansion. So maybe there's a couple of things that are driving this antigens, a couple of antigens. And also something hidden in the paper was this LL37, which is an antimicrobial peptide, which are raised quite high in these patients. And also these microbial peptides back in the 70s, they also have an anti-mitochondrial effect. So there's stuff emerging here around there could be something going on. And just the sort of final slides really. So this is some data I thought I'd show you from Soft Cell Biologicals in Utah. So they've been doing this work for about 5 or 6 years, 2,000 subjects. They've been looking at autoimmune conditions. So this is the data from the ME/CFS and the fibromyalgia groups. And what I'm showing here is they've found a way of culturing these organisms in the lab from blood. And what they're finding is there's much, much higher levels of culturable organisms in these conditions. So the ME/CFS and the fibro, much more than the autoimmune conditions, which also are high. As you get older, we have more culturable organisms. So this might be a factor of just getting older. And these organisms, as I mentioned, are really non-immunogenic. They sort of hide away, in our cells and tissues. And if they're in the brain hiding away, then they could cause trouble. And we're also finding them in tumors now and around in cancer. So this is a new and emerging area which could be really relevant in chronic conditions. And just to finish off, really, so this is an idea I've had. So, I've always wondered, how can mitochondria do all these things? They make energy, they make cofactors, they do reductive carboxylation, and maybe they're now responding to pathogens. So can one mitochondria do all of those, or do we have them compartmentalized? So do you have in a cell, some mitochondria make energy, cofactors, others make building blocks, and then a pathogen? And this is balance that's important. And so if you have a healthy muscle cell on the top right-hand side with a little bit of an infection, you can cope. You have a good mitochondrial energy producing system. But if that cell becomes compromised with the pathogens, you overdo it, you allow the pathogens to take over, and then maybe the balance is wrong, then you have less ability to make energy. And if you think about a brain cell with even less mitochondria, it's going to be even more compromised. And so just to summarize, really, what do we know about energy dysfunction, and where does it sit, which is a key question in the disease process? Is it a driver, or is it something that's a consequence? So there's clearly an evidence for an energetic defect in PBMCs from patients, and that's been established in many labs now. It seems to be more of a problem of flux as fuel rather than mitochondrial damage. The mitochondria seem to be fairly well and fairly intact. Reduced levels of amino acids in bloods, in lipids, that's been seen by quite a lot of groups now. So there's something going on at the metabolic level, but what it means is another question. Maybe it's increased fuel use or something else. There is a plasma factor, but we're starting to see it in controls as well. So we're not quite sure what that means. So there's clearly something in the blood of anybody that can change mitochondrial respiration rates, and we're just working on that. We don't really know much about what's going on in infected tissues, and this needs to change. We need to do more on muscle and brain. There's work going on in Oxford that's looking at this, but we need more of a budget. We can't work with £50,000 from a charity to do this. And pathogens, it's an area that we're very interested in. How do we study them? We can do deep sequencing now. We can pick them up in blood. We can culture them. So there's more we can do. And just to finish there, this is what we'd like to see. Really understand the system. What are we doing? We're really focusing on the gut as a potential driver, and we're bringing in these other areas to try and work with that. I've got 2 PhD students that just started, so we're okay for the next couple of years. So we can do something which is quite nice for us working in this space. Where these fit in is another question. Obviously, we can't do everything, but they fit in somewhere. It's been mentioned already in this meeting. So just to acknowledge my group. So I've got a really good group in the lab. So Jamie, who was on the previous slide, works on the bioinformatics. And at the bottom, there's ME Association. And actually, the local patient groups have been really helpful in terms of funding. And we work with a couple of groups here. So I will, one last plug. We have a meeting in April called Mitox. This is probably the best one-day mitochondrial meeting in the world. You can ask Andrew Murray. He comes every year. So I will stop sharing and sign off if I can work out how to get out of my slides.
Thank you very much, Carl. I'm sure that this will generate some discussion points in the panel discussion, and again, encourage people to ask questions. I'm going to now move on to Rona Aston, who's a colleague and consultant in ventilation medicine from University College London, and he'll be talking about long COVID. What does cardiopulmonary exercise testing tell us? Over to you, Ronan.
Thank you very much, and thank you for inviting me to speak today. So I'm the clinical lead for respiratory medicine at UCLH and also the lead for respiratory physiology, as well as being a senior researcher at the Institute of Sport, Exercise and Health. And so we're going to spend the next 20 minutes or so looking at some of the CPAP data and seeing what it can tell us about the symptoms and mechanisms of long COVID. In contrast to some of the previous speakers, none of these data are my own, which perhaps gives me a bit of an agnostic view. I've had to cherry pick quite considerably due to time constraints, but hopefully it will at least provide some food for thought. I have to say it's been a little bit difficult to amalgamate the various studies differing as they do in study Cohort, CPAP protocols, data provision and interpretation, but I think some patterns do emerge. I have no declarations of conflict or interest. However, I do have declarations of bias, and I say that because in my clinical life, I run an unexplained breathlessness and exercise limitation service in which we heavily rely on CPAT. As well as that, my PhD thesis was into the role of renin-angiotensin systems in regulating mitochondrial function, and my current research interests are really in muscle dysfunction and impaired oxygen utilization. So as you can imagine from the off, I viewed long COVID through a particular lens, feeling like many researchers that it was my area of interest that the answers lay in. Perhaps I was one of the blind men that Boone was referring to. And this view was reinforced early in the days of our long COVID service at UCH, run by my friend Hyman, because breathlessness, fatigue, and myalgia were very common symptoms in the cohorts we were seeing. And I remember thinking at the time and stating that if only we could put all these patients on a CPAP bike, we'd soon have the answer. However, I don't need to tell this audience how naive that view was. As we've seen throughout the talks today and yesterday, long COVID is much more complex than that, and it has a much greater array of symptoms. It was never going to be the case that CPAP would be able to explain such a complex symptom set. However, I do propose that exercise limitation and exertional breathlessness are common symptoms in long COVID, and we know from our clinical experience that static testing in these circumstances is insensitive. So exercise testing should have a role. I hope that in exploring the interaction between the cardiac, respiratory, circulatory, and peripheral pathologies by way of CPAP, that we might shine a light on mechanisms that might explain some of the wider symptomatology. However, straight away, we're faced with significant limitations by the data available to us. Much of the CPAP data we're about to look at relates to post-hospital discharge patient cohorts, whilst we understand that the large majority of patients with long COVID sufferers were not hospitalized. Moreover, their symptomatology significantly differs between those hospitalized and non-hospitalized. So we have to bear this in mind as we look at the studies that I'm about to present. But with our first study, we seem to have been given the answer: deconditioning. So this was a post-hospital study about 3 to 4 months post-diagnosis, with patients having suffered COVID pneumonitis and with the majority still actually having evidence of parenchymal involvement on CT scan. They used a fairly standard CPAP protocol with cycle ergometry. So first, this seemed like a legitimately maximal testing study with RERs greater than 1.1 and decent lactate rises. They reported a 55% prevalence of exercise intolerance in this study, characterized by a reduced VO2 peak at lower workload and an earlier anaerobic threshold. The main pattern of limitation appeared to relate to a significant reduction in VO2 work rate, significant at least statistically, although the figures in clinical practice wouldn't immediately cause alarm bells. But this was also in combination with a clinically reduced oxygen pulse. And these are features that one might relate to peripheral muscle dysfunction. Neither pulmonary function tests nor CT imaging helped discriminate the patients with a lower VO2. Breathing reserve was maintained, and there was no difference in ventilatory efficiency. So from this study, we perhaps can conclude that reduced exercise capacity at 3 months post-hospital COVID was characterized by reduced VO2 max, an earlier AT, and reduced O2 pulse. However, is that deconditioning? The authors certainly seem to think so. However, I'm a little more dubious. In my mind, deconditioning is a complex process of physiological change as a result of disuse. And I'm generally nervous to use the term unless I can show a response to training. The definition used in this paper, and actually that one employed by the European Respiratory Society in their guidelines, seems to encompass other pathologies under the banner of deconditioning. Now, there are some patterns on CPAP that can be more convincing of a muscle pathology, but without measures of cardiac output, peripheral oxygen uptake, it's really difficult to identify these more subtle changes. But this study aimed to answer some of those issues. However, again, it was a study at hospital discharge, so this is certainly not satisfying the long COVID definition. That said, it seems to identify pathology which might explain some of the longer-term symptoms. And although this was a small study at a single centre in a population having suffered significant COVID pneumonitis, these patients were symptomatic in a similar way that we see in long COVID. And importantly, it provides us with direct measures of the cardiac output in exercise, as well as arterial oxygen content, and oxygen extraction determined by resolving the Fick equation. Now, there are some concerns about the validity of the data, with the RAR in the COVID patient group being significantly, well, not statistically significantly, but not reaching the 1.1 threshold that we normally use to signify a maximal test. And with that, the lactate levels achieved were modest. This makes interpretation of the reduced VO2 peak, O2 pulse, VO2 slope, heart rate, and blood pressure a little bit difficult, although they were all in the direction as previously demonstrated of reduction. However, when we look at the indices of oxygen extraction, there seems to be significant differences. And while we might accept the possibility of submaximal exercise in this study, the trajectory of the oxygen extraction is clearly different between the two groups, with a failure in the COVID patients to increase oxygen extraction beyond about 11 mils per deciliter. And whilst the VO2 max differed according to disease severity, here being mechanical ventilation, non-invasive ventilation, or oxygen requirement during their index illness, the oxygen extraction index was similarly reduced across disease severity. So, although there's significant limitations in this study, and it was at hospital discharge, it does seem to suggest that the reduction in physical fitness in the COVID cohort is related to a reduced peripheral oxygen uptake, which obviously points towards a peripheral muscle pathology. Also worth mentioning, in this study, they saw a difference in ventilatory efficiency. And this seems to be a combination of higher respiratory rate and increased dead space ventilation, together with, in some, an apparent increased chemosensitivity. So we have potential pathologies identified at hospital discharge, but what about later down the line, where we might actually be meeting long COVID patients? So this study was in a larger cohort from multiple centres, and was performed about 3 to 4 months post-diagnosis, though it was still in a previously hospitalised population. This was a treadmill test in a cohort with severities of breathlessness which ranged, and unfortunately there was no control population. It was probably maximal given the RAR and lactate, and they found, similar to the previous study, a reduced VO2 in about a third of patients. As before, there was a reduced O2 pulse, although the authors didn't declare whether that was in the same group as those with a low VO2. And as before, there was evidence of inefficient ventilation, with 46% of those defined as dysfunctional breathing. Also of interest, when comparing those with significant breathlessness, as measured by the MRC scale, and those without, the raw VO2 max, anaerobic threshold, peak lactate did not discriminate. Instead, it was actually the BMI and the expression of VO2 per kilogram, together with ventilatory inefficiency, that separated the two groups. It would have been interesting to see if symptoms of exercise intolerance rather than just breathlessness better match the CPAT outcomes, but these data weren't presented. So for this study, we perhaps conclude that 3 months after hospital discharge, about a third of COVID patients have reduced VO2 peak, and that breathless patients have evidence of inefficient ventilation and associated increased BMI. Importantly, perhaps an impaired heart rate response. So taking that a step further and trying to better define the reason for that lower VO2 max, this study looked to dichotomize around a VO2 peak of 85 as indicating exercise intolerance and investigate defining variables. Again, this is a post-hospital group, but around 4 months from diagnosis and still with significant symptoms. Around 60% still have dyspnea or exertion and fatigue. There was no control group, and it was a single centre study like many of the others. There was also a range of comorbidities, including cardiac disease, diabetes, hypertension, though we'll see later that this didn't differ between the two groups. These tests appeared maximal in view of the RAR, and that being achieved at a lower workload in the exercise intolerant group. The large majority in both groups stopped exercise due to exhaustion or leg fatigue. The exercise limited group had a significantly reduced VO2 peak and an AT occurring at 53% of predicted peak versus 68% in the preserved group. The pattern of dysfunction in the low VO2 cohort was that seen earlier, with a low oxygen pulse at the bottom of the screen, confirmed in correspondence with the authors, in the setting of preserved baseline stroke volume, but with a reduced oxygen uptake efficiency slope. And this is a pattern again suggestive of a peripheral oxygen uptake defect. Interestingly, as before, peak heart rate also seemed to be a significant marker, which the peak heart rate being lower in the impaired group, and perhaps pointing towards some autonomic dysfunction. Unfortunately, in this study, they didn't report the VVCO2, so they can't comment on ventilatory efficiency. However, whilst peripheral limitation was the main exercise issue in 50% of the impaired, it's probably important to note that respiratory and cardiac limitations were also found, so this is quite a mixed group. Furthermore, again, symptoms did not correlate with VO2 max, and this time they included fatigue as part of those symptoms. So for this study, perhaps we conclude that, again, about 3 or 4 months following discharge, approximately 50% of patients with reduced exercise performance at CPET had peripheral mechanisms of impairment. However, again, there was no clear association with VO2 peak and symptoms. So that's the picture at 3 months. But we know symptoms and impairment go on much longer than that. And this study goes some way toward demonstrating the pathology in those timeframes. They looked at CPET variables from 3 and 6 months post-diagnosis. It's a small study, single center, and again, hospital discharge group with varying disease severity and comorbidity, so a number of potential confounders. However, the patients did have significant symptoms at 3 months and quite extensive, as we've become accustomed in the long COVID cohort. And positively, they demonstrated an improvement in VO2 peak, O2 pulse, and VVCO2 slope over that time frame of 6 months. They're not quite reaching the level of age and gender matched controls. In fact, looking at data more closely, we see that the group as a whole returned their VO2 max to a clinically normal level. So at first glance, this might suggest that there's now, at 6 months, no correlation between ongoing symptoms and exercise capacity. However, importantly, you'll see here that there's a sub-cohort. In fact, the cohort of patients who had a VO2 max less than 80% predicted, who do not improve over the 6 months. They seem to have a more fixed defect. So whilst exercise function improves in the majority over 6 months, there seems to be a persistent limitation in about 20%. And in effect, it's that 20% that this study examined, and finally in a non-hospitalized population. So in the study, the researchers tested only 10 people, but with 10 controls, all of whom were still experiencing symptoms of exercise intolerance. So a defined cohort. The controls were gender and age matched, and testing occurred around 11 months after diagnosis. So this is a long COVID cohort of patients suffering exercise limitation who did not have severe enough illness in the index illness to require hospitalization. And most importantly in this study, I think, is the fact they performed invasive CPET. That is, they floated the pulmonary artery catheter and placed a radial artery catheter so they could directly measure cardiac output, oxygen delivery, and oxygen extraction. And these are the results. So at 11 months, the VO2 max was still significantly reduced in the COVID cohort. However, there was a maintained oxygen delivery, that is DO2, and maintained stroke volume. So what's going on? Well, in fact, the cardiac output response was robust, representing actually about 115% of predicted value in the COVID cohort, and DO2 was preserved. But in both controls and patients, throughout incremental exercise testing, increases in VO2 were driven by increments in both oxygen extraction and cardiac index. However, unlike control participants, at 75% peak and peak VO2, further increases in VO2 in the patients, in the COVID patients, was limited by failure to increase oxygen extraction. So you can see the difference between the peak oxygen extraction for controls and that reached by the COVID cohort. This then is powerful data, albeit in a small selected group of individuals. Their exercise intolerance is limited by peripheral oxygen extraction. Which begs the question, where is this limitation occurring? Is this microcirculation? Is it mitochondria? Is it something in between? And this study potentially adds to that conversation. So in it, they try to assess mitochondrial function by way of looking at lactate clearance and fatty acid beta oxidation. And they did that by using stoichiometric calculations and gas exchange. Obviously, with fitter individuals, there is a higher rate of beta oxidation and higher lactate metabolism, resulting in lower circulating lactate levels at any given power output. Again, this is a single center study, but with a majority of subjects drawn from community long COVID clinics, and about 50% were dyspneic on exertion, with a quarter suffering decreased endurance. So in the cohort as a whole, about a third had reduced VO2 max, and in those, the majority had the same pattern as previously demonstrated, with reduced O2 pulse and a high heart rate reserve. And when they examined the lactate levels and beta oxidation rates, there seemed to be a very significant difference between the patient population and the controls, with apparent significantly increased levels of lactate production or decreased clearance, and an earlier switch from fatty acid oxidation, both of which are pointing towards mitochondrial dysfunction. However, I've got to say there were some major limitations in this study. So unfortunately, the control population was studied using a different study protocol with more like a steady state or a range of steady state tests of 15-minute duration. The control group were also 10 years younger than the patient population. And whilst they were said to be moderately active, they actually exercised 3 times a week, and it wasn't declared what that exercise consisted of. So possibly not a very reliable comparison group. However, these are interesting data, and I think perhaps provides a signal that metabolic disturbance might underlie the exercise dysfunction seen in these previous studies. And this is hopefully where a study that I'm part of might come in. So we're currently conducting a study at UCL where we aim to assess the key components of the oxygen transport pathway and compare results between 2 groups of long COVID patients, those with severely impaired exercise capacity versus those with persistent fatigue but preserved exercise capacity. So in the study, we'll look at 56 patients, all of whom being referred from a clinical long COVID service. And in it, we'll be assessing exercise function via CPET, muscle strength assessments, but also using near-infrared spectroscopy of the vastus lateralis and gastrocnemius, together with 31 phosphorus magnetic resonance spectroscopy of the gastrocnemius, with an aim to biopsy a subcohort in the vastus muscle. So I'm hoping this will shed a little bit more light on the question posed as to where the limitation might lie, and we hope to report in late 2022. Now, I've run out of time, but I do want to just show 3 last slides, which I'll run through quickly because I don't want to be too blinded or blinkered in the view of these CPET data. One of the common threads through the study is that of impaired heart rate response. And there are a number of studies now published which speak to this. This is quite a neat study from a Spanish group in which they use CPET to identify patients with potential chroniotropic index incompetence, and then test that more specifically or sensitively on a Bruce protocol. And in that, they found about 12.5% of patients with post-COVID were diagnosed with chroniotropic incompetence. Then there's this study, and I won't dwell on it too long because this was produced by a group with Oliver O'Sullivan, who very eloquently presented these data yesterday. But I think, again, it adds to the story. So in a large group of patients of over 200, they screened for autonomic dysfunction. And ultimately, they found about 25% of subjects had evidence of dysautonomia. Those patients were a bit older, had higher BMIs and waist circumference. But interestingly, no differences were observed in the RER at peak exercise for patients with and without dysautonomia, and there was no difference in their symptoms. They did have a reduced VO2 work rate. They didn't have a reduced VO2 work rate or oxygen pulse, but did have a reduced VO2 peak. So these two slides just point towards evidence that there may well be a role for autonomic dysfunction in this population, perhaps as a second pathology or second mechanism of limitation. So to wrap up, I think it's fair to say that there's actually a paucity of CPAP studies in the community of long COVID patients. From the data available, it seems that ventilation limitation rarely explains the reduced exercise performance. But it does seem that there's a subset of patients with reduced exercise performance in which there appears to be a peripheral pathology. That seems to relate to oxygen uptake limitation, although the details of that are not yet known. There does seem to be ventilatory inefficiency, and that can either be through increased dead space or chemosensitivity set point shift. And as we just mentioned at the end, autonomic dysfunction seems to be playing a role in some, although perhaps a separate cohort. And finally, I'd say that, as evidenced in these slides, I think the standard non-invasive CPAP now might be too blunt a tool to unravel the pathology any further. Thank you very much for listening, and I look forward to the conversations at the end.
Thank you for the really interesting talk, Ronan. So I'd like to welcome our last speaker, Professor Rezia Pretorius from Stellenbosch University, and she's going to talk about the insights into clotting and platelet pathophysiology in long COVID and PASC. Over to
Hello,
you.
everyone. Hello, everyone. Today, I will be sharing with you our latest research on clotting pathologies and will spotlight our recent findings in COVID-19 and also long COVID. The work that is presented here was done with both clinical and research collaborators. Professor Douglas B. Kell is from the University of Liverpool and a systems biologist. Clinician Dr. Jaco Loopscher is a private practice clinician at the Medikliniek Stellenbosch. The hematologist Dr. Jan Steenkamp, Dr. Marie Vlok, who is a biochemist, and at our proteomics lab, Dr. Chantal Venter, who is a physiologist, and our team of researchers at the School of Data Science and Computational Thinking at Stellenbosch University. Ethics approval was given by the Ethics Committee of Stellenbosch University, and Medikliniek Private Hospital Group approved sample collection at their facilities. My laboratory and our collaborators from various labs over the world have been identifying inflammatory molecules in circulation that might be involved in and drive pathological clotting. And we have also focused our research endeavors on studying the effects of increased circulating inflammatory molecules and how they interact with cells of the hematological system. We focus in particular on platelets and red blood cells, as well as on the clotting protein fibrinogen. We are also interested in identifying novel inflammatory molecules that might play a role in the persistent symptoms of long COVID. Over the years, we have published numerous papers that show the importance of inflammatory molecules in circulation and their role in abnormal clotting. I'm particularly interested in platelet signaling and the role in abnormal clotting. Platelets in circulation play a critical role in healthy blood clotting. However, they can become overstimulated and can drive pathological blood clotting if there are inflammatory molecules present in circulation. This can also happen in the presence of viral infections, where platelets can act as important signaling entities. There is also a complex relationship between receptors on platelets and endothelial cells, where circulating biomarkers may bind to. As we all know, damaged endothelial cells are also hallmarks of cardiovascular disease and COVID-19. We are also interested in the molecule P-selectin, which is a biomarker inside platelets and endothelial cells, but that can also act as an adhesion receptor on platelet membranes or as a soluble biomarker in circulation. The clotting protein fibrinogen is also one of the molecules we have studied, as it plays an important role in clotting and also pathological clotting. It can also act as a circulating inflammatory biomarker that can bind to various receptors on platelets. Lately, the importance of damaged endothelial cells, platelet hyperactivation, and aberrant clotting has also been recognized in COVID-19. In the context of COVID-19, platelets are central in immune activation and general coagulation pathology. You might be familiar with the clotting pathways. Normal clotting not only involves the enzymatic pathway culminating in the formation of fibrin, but also platelet activation. Also important is the process of fibrinolysis, or breaking down of the blood clots when it forms. Myself and Douglas Kell have also had a keen interest in the structural changes and the biochemistry of fibrinogen and how circulating inflammatory biomarkers might directly bind to the clotting protein to induce protein misfolding. If you focus your attention to the two cartoons shown in figure A, on the left is a healthy protein structure which has many alpha coils and few beta sheets. However, in the presence of inflammation, oxidative stress, and circulating molecules, these structural change where the alpha coils untwist into beta sheets, as seen in A in the cartoon on the right. In plasma clots from healthy individuals, these clots have more alpha coils and have the ultrastructure shown in figure B. Various inflammatory conditions, including cardiovascular disease and diabetes, have a clot structure similar as shown in C. Many proteins can adopt a thermodynamically stable microstate with no change in primary structure or its sequence, in which the more stable state contains an ordered beta sheet or amyloid structure. Normally, however, it is present in a less stable state that is kinetically more accessible during and following its synthesis. The more stable state, labeled here as PRPC, is separated from the initial state, labeled here as PRPC, via a large energy barrier. This is true for amyloid proteins generally and is illustrated here for the classical prime proteins. So with our knowledge of platelets and abnormal plasma protein structure, in various inflammatory conditions and cardiovascular disease last year, we focused our attention to COVID-19. Here is a cartoon that depicts the progression and severity of acute COVID-19 disease and what happens to fibrinogen. In a healthy individual, fibrinogen is soluble. The structure of soluble fibrinogen changes to form fibrin-containing microclots, and the action of thrombin and formation of D-dimer are pathological, where D-dimer levels are increased in very ill patients. We suggest that D-dimer production is similar when produced from amyloid microclots, but the rate might be considered to be slower. We looked at acute COVID-19 blood samples using the scanning electron microscope. Here you can see spontaneously formed microclots in whole blood from acute COVID-19 patients. Note the yellow arrows. In the micrographs on the left, you can see platelets are hyperactivated and clumped with numerous extensive pseudopodia formation. They have also shed their content and extensive membrane damage can be seen. Note the yellow arrows. In the micrographs on the right, platelet red blood cell interactions can be seen. These samples were taken from treatment-naive acute COVID-19 patients. A smear was made from a citrated blood sample after collection. We also looked at platelet-poor plasma and exposed it to our fluorescent marker theoflavin T, which bind to open hydrophobic areas in damaged proteins. This marker was first used to identify amyloid protein in brains of Alzheimer's disease patients. However, in 2014, myself and Douglas Kell discovered that theoflavin T also bind to misfolded fibrinogen and fibrin proteins during pathological blood clotting. Here we can see microclot formation in platelet-poor plasma in controls versus diabetes and acute COVID-19 demarcated as the green signal from theoflavin T. we found small areas of nearly undetectable abnormal microclots, which are present in plasma of healthy individuals, as can be seen in the micrographs on the left. More abnormal microclots were noted in plasma of individuals with diabetes. This is in line with our knowledge of the presence of hypercoagulation in type 2 diabetes, which is indeed well known. What was, however, quite significant to us was the extent of the abnormal microclots in acute COVID-19 plasma. See the micrographs from patients with COVID-19 on the right. Also note the scale of 10 micrometers at the bottom of the micrographs. We also looked at platelet hyperactivation, and using this information, we recently suggested a platelet and microclot grading system based on various stages of activation and severity of coagulation. Row 1 is typically found in healthy participants. In early 2021, we turned our attention to long COVID. The Long COVID Alliance, as we all know, in the USA reported that between 10 and 30% of patients struggle with the lingering numbers will not be too much different in South Africa. And therefore, in May 2021, we initiated the South African Long COVID Registry. In the Sankey plot on the left, you will note that brain fog and concentration issues are the most prevalent lingering symptoms in the South African long COVID population. The Sankey plot on the right, we show participant comorbidities versus long COVID symptom population distribution, high blood pressure being the most prevalent comorbidity before initial COVID-19 infection in our South African population. This data was generated by my collaborators from the Center of AI Research and is in line with what is known globally. We also looked at blood samples from these patients. We noted significant platelet hyperactivation and clumping in the blood of individuals with long COVID. In the micrographs on the left, you can see representative platelet micrographs of healthy individuals, and on the right, platelet hyperactivation and clumping, which are visible in blood samples from long COVID patients. Here are examples of microclots where we added THT, theoflavin T, the green signal, and another marker, Amitracker 480, which is the blue signal, as our fluorescent amyloid markers of choice. We also planned an experiment where we looked at proteomics of healthy plasma versus type 2 diabetes, acute COVID-19, and long COVID. We added the diabetes samples as we know that people suffering from diabetes are more prone to severe COVID-19 symptoms. For proteomics analysis, we prepared platelet-poor plasma from citrated blood, followed by a first trypsin digestion step. To our surprise, we found a visible deposit at the bottom of the Eppendorf tube in the acute COVID-19 and long COVID samples, but not in the diabetes samples, and also not in the control samples. Plasma proteins, therefore, were fully digested in controls and diabetes samples, suggesting that trypsin could degrade all or then at least most of the plasma proteins in both controls and the diabetes samples. For proteomics, the sample supernatant was filtered with a C18 filter. We also followed a second trypsin digestion protocol to solubilize the undigested pellet deposits. We analyzed 1 microgram of protein of the supernatant and also of the equivalent from the digested pellet deposit. We then viewed the unfiltered supernatant after the first trypsinization step using fluorescence microscopy. We found that plasma of patients with type 2 diabetes and plasma from healthy patients digested fully after a first trypsinization step. See the micrographs on the top left. In contrast, microclots in plasma from patients with both acute COVID-19 and those with long COVID did not digest fully with the first trypsinization step. Here we show microclots still present in plasma after this step. After the second trypsin digestion step, we could digest the microclots in plasma from both the acute COVID-19 and long COVID patients. We detected various inflammatory molecules that were substantially increased inside the now digested microclots of patients with acute and long COVID versus the equivalent volume of fully digested fluid of the control samples. Of particular interest was a substantial increase in the molecule alpha-2 antiplasmin and the various fibrinogen chains that were trapped in the solubilized fibrinolytic resistant microclots. Here is a simplified diagram to explain what in our minds happen with microclot formation that might either be resolved via the fibrinolytic process after acute COVID-19 or, in some patients, result in a failed fibrinolytic process, ultimately resulting in long COVID, characterized by microcapillary blockages, low oxygen in tissue, and eventually a general hypoxia. Briefly returning to alpha-2 antiplasmin, this diagram shows the clotting and lysis pathways that we are all familiar with. The molecule, alpha-2 antiplasmin, prevent clots to lyse, and if it is present in plasma of long COVID patients, it might, in part, be the cause of persistent microclots in circulation that do not break down via the normal lytic processes. We have recently collaboration with Dr. Beate Jaeger from Germany, who has treated numerous long COVID patients with great success. Together with Dr. Jaeger, we have been gathering like-minded researchers and well-respected clinicians all over the world. Hopefully the results of our collaboration will give other clinicians confidence in treatments like, for example, anticoagulation and HELP apheresis, and act as proof of concept for larger multi-center studies. A bit more on HELP apheresis. It is a technology now used to remove microclots from circulation of patients with long COVID. From a global perspective, more than 3,000 patients are treated with HELP apheresis every year. In this context, HELP apheresis is a well-established therapy with more than 30 years of experience and nearly 500,000 treatments worldwide. HELP is a highly selective kind of therapy. Atherosclerotically effective risk factors such as lipoprotein A, fibrinogen, and inflammatory factors are removed, in addition, apart from LDL cholesterol. Lately, Dr. Jaeger's team have also been using the treatment for long COVID patients, as just mentioned. Here is an example of microclots filtered from the blood of a long COVID patient. Just a few of our collaborators on long COVID. We hope to report back soon with more interesting results from our study that we conducted in November in Mulheim at Dr. Jaeger's clinic. Our future endeavors include the development of point-of-care diagnostic methods and more widely available methods that pathological laboratories can use where they could look at microclot analysis as one of their diagnostic methods. We desperately need randomized control studies that investigate treatment regimes that both block microclot formation and possibly prevent platelet hyperactivation. We are currently discussing 3 such possible trials in the USA, the UK, as well as Thailand. I end this talk with my website where you can find all my publications. Thank you.
Thank you very much. That was a very insightful talk, and lots of questions have come through with that as well. So I think everyone's going to come up on screen now for our panel discussion. We have 20 minutes to go through lots of questions, and hopefully that will get a discussion going. I'm going with and just go through systematically. I've tried to star questions so that there is representation for everyone. So first of all, to you, Dimitri, is there an association between post-COVID fatigue and the impairment in cardiopulmonary function in long COVID patients?
No. So that's what we tried to tease apart a little bit with our clustering analysis to see if any of our features were clustered either in a subgroup of our cohort or when they were homogeneously distributed. And we didn't find any strong evidence for coupling between the two.
Okay, and you kind of alluded to it that when you were doing the study, you had lots of variants kind of emerging through, but the dominant form of it was the alpha variant in your
yes. I mean, we sort of we basically looked at the genomic data in which variants were in circulation at the time of infection, and then for every one of our participants, we then estimated the probability that they had alpha or B1117. And as a cohort, we can say that about with 83% of our cohort were likely to have been infected with alpha, and a
Sure.
smaller subset with B1177.
And do you think vaccination played a part in that, in your observation?
I can't.
Or was it too early in the alpha? I'm not sure. Probably too early for the alpha.
I think it was a little bit too early. I mean, there's not our study. There's other studies that have looked at the impact of vaccination and long COVID, and it does offer some protection from long COVID, but it's incomplete.
Sure. And as in, there's a lot of overlap with what you're doing and what Boone talked about, and also Ronan. Any points to add to that question? No?
Sorry, were you asking me?
No, I'm asking Boone or Ronan. As in, there was a lot of overlap from that question with what you also talked about, Boone, and also Ronan. Any additional points to add to that question? No. Let's move on quickly. Does elevated resting heart rate point to autonomic dysfunction, or could it be that autonomic nervous system is operating appropriately in response to afferent stimuli?
I think both are correct, and I think we characterize the autonomic nervous system as a very responsive nervous system. So when your blood pressure is low, stroke volume is low, you're going to be chronically allowing some sympathetic activation to enhance the vasoconstriction and enhance the cardiac responses to maintain cardiac output. Because after all, cardiac output is a product of heart rate with stroke volume. So stroke volume low because plasma volume is low, blood pressure tends to be low, autonomic nervous system gets dialed up. What's really interesting is that the barrel reflex gain is the other component that we don't normally see very well in our standard upper arm cuff blood pressure single measures. That is the oscillations. And those oscillations, I think, give you a sign or a marker that the mechanoreflex in the baroreceptor, but also potentially the chemoreflex and the cardiorespiratory reflex are all kind of magnified. So they're at a resonating frequency that gain up and down. And I think part of the reason people are so symptomatic, and this is a kind of hypothesis, is that these oscillations, the pulsing blood pressure between, say, 150 and 110 systolic, are not taken very well by the brain. And so the mean arterial pressure and the perfusion in the brain may be compromised in that pulsatile manner. So I think both those theories are right in direct answer to the question.
Okay, thank you. And there's a quick question on the oscillation. Is it coupled to respiratory cycle at all? That was a question that was asked by
Emma. So in the initial stages of our tilt, we had a respiratory band. It broke, and it's a very fiddly tool. But yes, when you find the oscillations start up, the patient's respiration also increase. So a lot of these patients start to hyperventilate with a very disordered paradoxical breathing pattern, i.e. chest breathing, which is the opposite of what I demonstrated. And the cycle of breathing, I think, does match with the cycle of oscillations, although the breathing rate is a lot faster. Or the breathing rate can be preceding and a bit faster.
Great, thank you. Anna, I'll let you ask a couple of questions.
Let me just pick one. Are there any associated, is there any associated between structural changes in coagulation factors and the various COVID-19 variants?
Yes, we have now just been collecting blood samples from Omicron, and it seems that Omicron do not make so much microclots as we have seen from the other variants. So it's also reflected in the patients in the ICU units in South Africa. I'm not sure if that is the trend in the rest of the world. I do know some of our collaborators from New York, as mentioned, that they still have lots of patients very ill with clotting issues in hospitals. So it might still be a while until we know what happens with Omicron patients, whether they develop long COVID. So the issues that I'm talking about is the acute COVID. So I think we will see long COVID coming through now within the next month or so, and we will only then be able to determine whether Omicron actually also causes the long COVID symptoms as we typically see with microclots in all of the other variants.
And a follow up on that, what percentage of patients are responding well to apheresis?
Sorry, can you just repeat the question?
What percentage of patients are responding well to apheresis?
That we do not, I think, know. I think Dr. Beate Jaeger will be able to answer that. I think she has been finding that patients do need more than one treatment regime with HELP apheresis. They do respond well. However, the patients that respond the best are those that she's also been putting on a triple therapy. But obviously, there's lots of dangers involved with triple therapy, bleeding propensities. So it must be trialed properly with randomized clinical trials. I think that is the next thing that we desperately need to do, to see how the patients react. Long-term disease versus short-term disease, because I think the longer a patient struggles, then other pathways will come into play, including autoantibodies and other autoimmune type diseases. And it will be much more difficult to address the damage that is done by the general hypoxia that we see in these patients.
Can I just raise an extension and make a point, please? So I'm a cardiologist, and I see coronary atherosclerosis as one of the most prevalent autoimmune conditions that we have. After all, atherosclerosis is the a kind of infiltration of immune cells, macrophages, foamy macrophages, to then bathe the section of artery in a autonomic and cytokine milieu that attracts further macrophages and attracts platelets and activates platelets and clotting and so on and so forth. The analogy I'm trying to drive at is when I see a patient who has a 70% blockage or even 90% blockage, the trial data that is coming out, certainly from Imperial where I work, is that a conservative approach may be better. So when we see patients now and we do a stent, which is the whatever cardiology ocular stenting reflex, right, which we often laughed about, is a very simple thing to put a stent in, but a very difficult thing to tell the patients to reduce weight, to tackle diabetes, to stop smoking, because that takes time. And actually, the approach in the cardiology field has shifted from stenting lots to stenting little. In other words, really taking control of the risk factors. And I guess the question for you, Dr. Pretorius, is what are the major ongoing drivers that continue to produce these cofactors for platelet activation that need to be tackled before going into a downstream, as you say, 5,000 patient cohort, when we have an iceberg of the problem that numbers in the tens of millions across the world? So that's the kind of point I like to raise, because what other strategies can we work on upstream to help this clotting cascade from even starting off?
I think the important thing to note is that many people have been looking at viral persistence, where the virus might be present in the gut. And there was a study from Professor Akiko from Yale, who showed there's persistent viral virus in the gut lining and shedding possibly spike protein all the time. So I think the early mechanism would be to address that, the persistence of the virus in various organ systems, but then also perhaps taking a step backwards. But obviously that is something that one should also trial, is to perhaps prevent clotting to go into such a rampant phase where the persistent symptoms that we see that is just persisting and lingering in the long COVID patients. Perhaps we should focus more on treating clotting and platelet hyperactivation during the acute phase. But obviously, to do that is again, you need to address, I think, blocking the microclot formation to start off with, but also so to prevent it from forming, secondly, to block platelet hyperactivation, and then not, as you mentioned, have this overreaction of all the molecules affecting them in the end, the whole endothelial lining, so that you have a generalized endothelitis starting in the acute phase for some individuals that do not recover, and then lingering into the long COVID. So I think one should possibly rethink the mechanism of treatment in acute COVID. But obviously that is a clinical trial that needs to be looked into that as well.
Laura, do you want to take over? I think you're mute, Laura.
Okay, great. Sorry. I just say fascinating discussion points. And there are drugs available for these sorts of things, aspirin, hydroxychloroquine, that we know can stabilize the endothelium. But the challenging question is, at what point do you give these drugs to effectively, give a positive outcome? And I don't think we know that yet. And maybe getting it wrong at the point where we start, but we'll see as it evolves. I'm going to have a question for Carl. The plasma transfer assays with ME and CSF patients are fascinating and seem worth carrying on with long COVID patients. How could they be followed up, do you think, in terms of mitochondrial dysfunction?
Sure. Yeah, they're quite straightforward to run. We found a few issues with the cell model. So the model that you test the plasma on can have an impact. So our early work was on the primary muscle cells, and so there was quite a difference. Now we've started to look at different sort of tumor-based lines, so rhabdo muscle tumor lines and brain tumor lines, and the results aren't as clear-cut. There's a difference between what the plasma does from the patients compared to the control, so it has a longer term effect, but controls can do this as well. So there's something in plasma that can impact on mitochondrial function, increasing mitochondrial dysfunction. I think we need to look at serum and plasma, and maybe different types of plasma as well. So, but also, what is the best system to test this on? Should we be looking at some sort of stem cell models that can make neurons more primary? But it's going to take a bit of sorting out, I think. Interesting, but it's not clear cut. There's some interesting work come out of Ron Davis's group in Stanford looking at red blood cells, and also swapping back plasma from patients, and you see something very similar in terms of the red blood cells aren't very good at controlling, sort of working in high salt solutions, so they can't kick out the salt as well when they're in the plasma from the patients compared to the control. So there's something different there. We've done some heat experiments, so we can heat up the plasma and we lose this up to 70 degrees, so it's some heat labile molecule. We've also looked at vesicles that we've generated from plasma. They can do something very similar, but again, controls can as well. So it's just trying to tease out what's important. But yeah, definitely doing this in long COVID would be interesting to do. But I think the models need a bit of sorting out first. Actually, I have a question for Reza. Could I ask a question to Reza?
Sure, you can.
Reza, nice talk. Do you think that this microclotting might have a purpose? Because obviously you're taking out the inflammatory molecules, locking them up in some sort of difficult to break down molecule. Could that be useful? A bit like the tau amyloid stuff in the brain that we think maybe that's part of a protective mechanism. Could that be something that's working here as well?
Absolutely, I fully agree, especially if there's a spike protein that needs to be hidden away or getting rid of. So definitely that can also come into play. I think we still know so little of what is happening. And what I also have been noting, it's not published yet, we're just finalizing the paper. We looked at 100 long COVID patients in city controls, where we again digested the sample, and we looked at a little bit closer at the antibodies and autoantibodies. So I'm not an immunologist, and we're trying to still figure out what we are seeing, but we're finding a lot of antibodies trapped onto or inside the clots. So we think that the microclots might also drive the molecules trapped inside the microclots might also secondarily drive the autoimmunity that we might see in these individuals, especially if it is prolonged. But definitely what you say makes good sense, and I think it's definitely one of the mechanisms, but we simply don't know.
Okay. Laura, can I pass your question over to Boone? So you mentioned that the stress on the brain from this change in blood pressure could be important. So there's quite good evidence in sort of blood people that are brain dead in ICU. They turn off their kidneys, and they do it by turning off their mitochondria. I just wonder, do you think there's a sort of this stress on the brain could be driving potentially a lot of the other symptoms that we see, maybe the mitochondrial dysfunction that it seems to be in the periphery of these patients?
I have a very open mind, and I think there is an energetic element to the whole equation of long COVID, which we don't understand. And I certainly don't understand. I'm not a mitochondrial expert, and I don't really know that much about mitochondrial physiology. So your talk was very enlightening. Thank you very much. All I do know, and what I do know, is also how I feel since I've taken on this breath work. I've become a heart math trainer in the last 2 years, mainly to help myself practice and regulate my own emotional state and self-regulation, which is very much needed sometimes in clinics. But in doing so, I felt a lot calmer, peaceful. I've not had, touch wood, any significant infections, and I felt full of energy with less sleep than I used to have. So it is an aspect of overall health that I feel will contribute. And so the opposite question is depression, anxiety, what these states do to inflammation. We all know they create atherosclerosis, they create increased incidence of myocarditis, Takotsubo's cardiomyopathy, heart attacks, but also, I guess, problems with an acute vasoconstrictor response. And therefore, the opposite must be true. If the impact of brain physiology in terms of emotional states, thoughts, and stresses can create such tangible, measurable physiological changes, then what of the impact of meditation states, happiness, breathing, and coherence? What could those states do at a very, very high upstream level to kind of help to modulate some of these effects, including mitochondrial function? So the answer is ask ourselves. In fact, do it ourselves. Feel how you feel when you've done half an hour of breathing or in a mindful state, and feel the energy rise. And I don't know how else to explain the answer, but to say that is my experience, and that is the experience of a lot of people who have undergone this phenomenal long COVID recovery program with Susie Bolt, in that they feel a lot more energized after doing this basic work.
Maybe I could come in there as well and take the opposite tack, not disagreeing. I think everything Boone says makes entire sense. But if we're talking about trying to discern whether the mitochondria are functional but not stimulated versus dysfunctional, then we really have to look at mitochondrial function directly. And this is where I think deep phenotyping does have a role. I appreciate it's always going to be in a subset of patients, and there's all sorts of limitations there within. But I think, a lot of the work that Carl, you showed in your talk, if could be replicated in the long COVID cohort, would really shed quite a lot of light on some of the potential mechanisms. And looking at the muscle mitochondria directly or indirectly through imaging or ex vivo, I think is certainly one of the ways forward that we have to move in to try to better understand that dysfunction.
I think one thing just to throw in there, so in terms of selecting patients, it's been a real problem in MECFS. So we have to use questionnaires to select the patients, and people with depression, that is the driver of their symptoms, get included in lots of studies. And so it's trying to tease those out. You need to include them. They're a really useful group to have in there, because patients with these conditions will get depressed, just the nature of the conditions. But I think that's going to be a real, when we start looking at metabolomics profiles, we can get in a real mess with some of our cohorts because they've not been diagnosed as well as the other cohorts. And so what I showed, that data, those amino acid changes, we don't see those across the board in other cohorts. And we think perhaps that's a good thing, that you can maybe knock those things down. Maybe that mitochondrial dysfunction we see in plasma is evidence that these patients are doing better. These are the mild patients that seem to be coping better than probably the severe ones that can't do it. So, but I think the classification of this long COVID group, because there will be people in there that aren't long COVID, because it's not easy to pick them up. So I think that's really important going forward. And it's great that you're doing this. So Dimitrios, this is clinical assessment, because we've never had that in MECFS. We don't get that workup, except in the good cohort we have from Poland. They really spent 3 hours looking at all these different tests that you talked about in some of these presentations. And that's going to be really important, reproducing that across all the studies and having the budget to do that, because it's not cheap to do that.
Carl, can I ask you a question? I think I asked it offline in the presenter group.
Sorry, Boone, I'm going to ask a quick question because we're going to have to wrap up.
Oh, sure. Sure. So you want me to ask first, Laura? Sorry. Oh, no, sure, Carl. So I guess the question is this: I was very fascinated by your slide showing the lack of mitochondria in the brain relative to the brain's need for energy, and I just wondered how you felt about the alternate sources of fuel beyond glucose, such as ketones. I mean, that's all I know. I don't know about the other pathways, but I guess that resonates with some of my patients who say, since they've gone on a semi-ketogenic diet with intermittent fasting, which I also promote in some of my cardiovascular cohort, somehow the switch to ketosis helps brain function sharpen up, i.e. Improves brain fog. And I guess anecdotally and personally, when I also intermittently fast, and I feel much less sluggish in the morning, having not eaten anything for 16 hours, and can probably feel I can go on. So the brain fog element may be helped by ketosis. Is that something
I've heard that before from lots of patients say that. Actually, Cara Thomas, who ran those Newcastle studies, I don't know, Demetrius knows her, in Julie Newton, she was a patient, and she came to a meeting that we organized in Oxford, and I said to her, have you had any breakfast? Because she was in a B&B. Oh, no, I don't eat breakfast. I don't eat till lunchtime, because basically if she did eat, it really got her into that sluggish state, so she could cope much better. So it's a common thing. So I think this idea that maybe glucose isn't used as well for whatever reason is important. And going back to the brain stuff, there's less mitochondria, but maybe those mitochondria, they're factories for, because all of the proteins seem to be in the membrane. So if you look at those papers by the Italian group, if you take vesicles from myelin or ER from, and even rod cells at the back of the eye, there's lots of membrane region, but no mitochondria with the highest energy use of those cells. They have lots of mitochondrial proteins in there. So maybe it's a different type of system. This could be, a Nobel Prize type work if they're right, but people have just rubbished it and said it can't be true. So I think there's more to do, I think, there.
Great.
Take on the hard graft. I'll support you.
Yes. We're actually looking with them. Actually, some mouse rod cells at the back of the eye, and we're getting the stainings working. So proving, because if you make preps from tissues, there's always the contamination question that comes up. But you need to look at the tissue in situ, and we're starting to do that, and it does look interesting. That's all I'd say.
I'm going to have to wrap things up. Thank you all for your time and interesting discussions. We weren't able to answer all the questions, but there's Padlet. So hopefully we can link you up with the speakers and they can address those specific questions if possible. I just wanted to ask a quick question because there's a lot of overlap. There's a lot of overlap in terms of mechanisms. Microclots has been mentioned, mitochondrial has been mentioned, autoimmunity has been mentioned, which may interplay with all of those. And I just get to ask each of you individually, what do you think is the main focus, or do you really think that it's an interplay between all these factors? And we'll start with you, Ronan. Just a quick response, if that's possible.
I think autonomics and microcirc.
What did you say?
Autonomics and microcirculation.
Okay. And Carl, what do you think? I suspect you'll say mitochondrial.
Well, no, I don't actually. So we think the gut is crucial. We think there's stuff coming through in the gut that's causing issues with the patients. They don't deal with it properly, and these horrible L-form things end up in the wrong parts of the brain. And maybe the response to mitochondria is the body trying to deal with them. I think that could be part of the package. So mitochondria involved, but maybe they're not the primary driver. Something else is doing that.
Okay, Boone?
I'm going to go with trying to see the whole elephant, but if I had to pick one aspect, it would be autonomics and work needing to be done on the pre-existing psychological and physical profile of patients, because they're of this particular type of predisposition, this long COVID community. And so those predisposing risk factors are there already.
Okay, Demetrius.
I don't want to just repeat what Boone said, but my sort of take is to consider not just any particular element, because we think of the brain, we think of the immune system as separate entities, but they both coexist in the same body ultimately, and they can all influence each other. So one thing that I would sort of think needs a bit more attention is the impact of neuroplasticity, how circuits change in the long run after 3 or 6 months, and of course the immune system and all the impacts that can also have.
Thank you. Risa?
microvasculature, general state of hypoxia, and gut dysbiosis, I think, tied into all of this and ending up with autoimmunity.
Excellent. And Anna, have you got any points to add to that? You're mute, I think.
That hasn't been mentioned, but I wonder if the lung biome has any role to play in this. It's another organ that's open to the exterior world, and we talk a lot about gut biome, but the lung has its own biome. It's primarily affected by the disease. Any thoughts?
Any quick response to that, being a respiratory person?
Very interesting. I've not seen much data, but I think it's something worth looking at.
Okay. Great. Thank you all very much for your time. It's been an interesting session, and I hope the virtual audience enjoyed it too. And we'll try and see if we can answer your questions offline. Thank you all.
Thank you all.
Thank you.